So hello everyone. So today we are going to deal with a more number of obstetric topics. So this will be a little, many number of topics are discussed here, but not just in a high yielding, all high yielding topics have been taken up, and in a just exam point of view, what is the necessary points to be remembered. So this will be the last session of obstetrics when it comes to obstetrics. So let's see what and all topics have been covered. So these are the topics that have been covered, around 12 topics. I know it is a lot number of topics for a short period of time, but still, these are the important topics when it comes to competitive exams. And more than in detail, these have been given importance of what are the high yielding points, or what are the highly rememberable. Like you have to know these points in these particular topics. So such points have been discussed. So let us go about it. And coming to the first topic, maternal pelvis. So maternal pelvis and fetal skull. Either one of the question will be asked in among the two. So we'll see. Now coming to maternal pelvis. So starting with angle of inclination. So a pelvis angle of inclination when it is an erect posture. Erect posture, a female pelvis is tilted forward at the angle of 55 degrees. So this you have to remember, the degrees at which the female pelvis is tilted forward and to the horizontal, so not vertical, to the horizontal, it is 55 degrees. And why this is important? This is important when a pelvis is observed or assessed whether there is a high inclination or low inclination. So when it comes to high inclination, if there is a high inclination and high angle of inclination, so it has got some obstetric significance, because if the angle of inclination is more than 55 degrees, then what happens? It will lead to delayed engagement of the head, and it favors the most favorable position for a high inclination pelvis, angle of inclination pelvis is occipito-posterior position, and there will be difficulty in descent because engagement is not be able to happen, and descent is not very easy. So this is the significance of a high angle of inclination in a maternal pelvis. When it comes to low inclination, it doesn't have any obstetric significance. That means if a maternal pelvis has a low angle of inclination, it is well and good, because there will be no any complication or no difficulty when it comes to the stages of labor or mechanism of labor. Next, the diameters. You have to remember which is the narrowest transverse diameter. So there are two diameters which comes into the picture. So it is a transverse and the antero-posterior. Antero-posterior diameters. So which is the narrowest transverse diameter? It is bispinous diameter. Bispinous diameter, which is seen or which is measured between two ischial spines, and the measurement. So this topic, whatever measurements, wherever you see, you have to remember, because very easily this can be asked as a question and very easily confusing for a aspirant. So that is why you have to remember, make a note of all the diameters, whichever comes up, anterior, posterior, and transverse, and make a note of what is the measurement. Very important. So bispinous diameter, the measurement is around 10.5 centimeter, and it is the narrowest transverse diameter. Next, coming to types of pelvis, very important topic, because there are a lot of questions in our previous question papers. So coming to first type, gynecoid type, or it is also called as round type. Again, I'm repeating that whenever you see the other name, you have to remember the other name of any topic or any term for that matter. So gynecoid pelvis is also known as round pelvis, and it is the most common type of pelvis in a female. So it is around 50%, and that is why it is also called as normal female pelvis, because the incidence of gynecoid pelvis is high. And why it is normal female pelvis, and why it is a favorable pelvis, because the normal vaginal delivery is possible without any difficulty. So this is an ideal pelvis type of pelvis, gynecoid or round pelvis, and there is wide subpubic angle. So when there is wide subpubic angle, the engagement, the descent, it happens very easily. So there will be no difficulty. So that is why. So you have to remember gynecoid, you can relate that way. So female pelvis, normal female pelvis, and which is the most common type of pelvis? You have to remember it is gynecoid pelvis, and which is the least common type. So this is the first, that means most common. The least common type is this platypeloid. Okay, so here coming back to gynecoid, so normal vaginal delivery is possible without any difficulty. Next type of pelvis is anthropoid pelvis. Anthropoid pelvis, it is also called as antero-posterior oval pelvis. And why the antero-posterior comes into this picture, anthropoid pelvis? Because so it is, there is a slightly narrow subpubic angle, first of all. And why the term antero-posterior oval? Because antero-posterior diameter of this pelvis is more than transverse diameter. So there are two types of pelvis where it is vice versa. So a question can be asked, in which type of pelvis the antero-posterior diameter is larger or higher, or measures more than transverse diameter? It is anthropoid, whereas transverse diameter measures more than antero-posterior diameter in platypeloid. So AP oval means anthropoid, AA. Remember AA like this. And AP is more than, that is antero-posterior diameter is more than transverse diameter. And here non-rotation is common because there is narrow space, the internal rotation, which is the most important step when it comes to mechanism of labor, that becomes difficult in anthropoid pelvis. And direct occipito-posterior position. So what is the position, common position of the fetus that takes up is direct occipito-posterior is common, and more chances of phase to pubis delivery. Next type is android. So by the name you can just relate. Android means male. So here it is a male type of pelvis. So there are three names: android pelvis, or triangular pelvis, or heart-shaped pelvis, and male type pelvis. So all the four terms you have to remember. Don't get confused. So android pelvis is also called as triangular pelvis, or heart-shaped pelvis, and male pelvis. So male type of pelvis. So here there is narrow subpubic angle. There is delayed engagement. When it is narrow, obviously engagement occurring is a little difficult, and a difficult anterior rotation of the fetus, and more chances of deep transverse arrest, and which is a very the condition is very critical here. When there is transverse arrest, immediately the mother or the pregnant lady should be taken for C-section, because the fetus is not able to descend, and the fetus can go into distress, and that is why this android pelvis is a difficulty for normal labor or normal vaginal delivery. And persistent occipito-posterior position is the common one, and difficult instrumental delivery and perineal injuries. Instrumental delivery means the assisted deliveries with forceps. Okay, so that is difficult here. And if it is seen that the female is having an android pelvis, so normal delivery or normal vaginal delivery, them trying is a rare thing, because there will be difficulty, and that is why directly it is taken for a C-section, and there are incidences of perineal injuries also. Next type is platypeloid pelvis, and platy means flat. The word meaning of platy means flat. So here the other names is transversely oval. So why transversely oval? So here anthropoid is antero-posterior oval, because antero-posterior is more than transverse. So here transversely oval because transverse diameter is more than antero-posterior diameter. So it is also called as transversely oval. And when you relate to the name platypeloid, flat bowl-like pelvis, flat bowl-like pelvis. So you should remember all these names. And what is the specialty? One common thing that can be asked is, which is the least common type of pelvis? Can be asked. So it is a platypeloid type of pelvis. Here, what is the problem? Very wide subpubic angle. Very wide subpubic angle, more than 90 degree. So that means transverse diameter is more than anteroposterior diameter. And anterior rotation here occurs late. Head engages with marked asynclitism. So engagement, if we had already done that session. So engagement, what happens? There is synclitism and asynclitism. And the types of engagement. In asynclitism, again, it is anterior and posterior. So here, head engages, whereas if a woman has a platyploid pelvis, the engagement is a asynclitism type of engagement, and engagement diameter is usually subparietal, super subparietal. So there is no difficulty in delivery if head is able to, is able to negotiate the asynclitism or else C-section. So asynclitism is not a abnormal engagement. It is normally occurring, synclitism and asynclitism. And if his head is able to pass through that type of engagement, then it is okay. Normal delivery can happen. If not, then it is taken for C-section. So these are the types of pelvis. So just remember 4 types: gynecoid, anthropoid, android, and platyploid. And you have to remember all the other names, and which is the most common, gynecoid, and least common is platyploid. Next, coming to obstetric significance of plane of least pelvic dimension. So narrowest plane in the pelvis. So why it is important? So when it least plane pelvic dimension becomes very important in when it comes to labor, especially. So what is the importance? We'll see. So because it is the narrowest plane in the pelvis, plane roughly corresponds to the origin of levator ani muscles, and it is at this plane that internal rotation of the head occurs, and that is why it is the most important. And when we saw the mechanism of labor, which was done already, we saw that which is the most important steps among the mechanism of labor, it is internal rotation, because if this step doesn't occur, then the fetus will not descend and the further labor will be arrested, and it is a critical condition. That is why this is the most important step in mechanism of labor. And what aiding for this labor in the pelvis, and it marks the beginning of the forward curve of pelvic axis, and it is the landmark for pudendal nerve block analgesia. So if at all analgesia should be given, this is the plane where it is given, and the level of ischial spines indicate the station 0. So we saw when the head is engaged, it is called as station 0, and the engagement usually occurs with the narrowest plane in the pelvis, and it is irregularly oval and noticed on each side by ischial spine. Now, which are the antero-posterior diameters of the pelvic inlet? So here you can see true conjugate, diagonal conjugate. So there in transverse, we saw the bispinous diameter. So when it comes to antero-posterior diameter, there are 3: true conjugate, diagonal conjugate, and obstetric conjugate. So there are 3 diameters. So usually the antero-posterior diameter is usually seen from the midpoint of sacral promontory. So this is the starting point from where the measuring is taken. It is measured, and where it goes gives the type of diameter. So the beginning point is always the same. It is sacral promontory, midpoint of sacral promontory. And if it goes to upper border of symphysis pubis, it is called true conjugate. If it goes to lower border of symphysis pubis, it is called diagonal conjugate. And if it is in the midline projection, middle, in between, it is called as obstetric conjugate. And you should understand this is the most important diameter for when it comes to obstetrics or when it comes to labor, normal labor. And so what is it? It is the midline projection of symphysis pubis. So sacral promontory to upper is true and lower is diagonal, and midline that is in between is obstetric. Now, what is the length of true conjugate? It is 11 centimeter, diagonal is 12, and obstetric is 10 centimeter. And true conjugate is also known as anatomical conjugate or conjugate vera. And what is the speciality of obstetric conjugate? It is the shortest antero-posterior diameter. So which is the shortest anteroposterior diameter? It is obstetric conjugate. And which is the shortest transverse diameter? It is bispinous diameter. So these two diameters you have to remember, because these have been asked as questions in previous years. Now, what is the importance, or what is one speciality of these three diameters is both true and obstetric cannot be calculated, or cannot be calculated clinically. Clinically, by assessing, it cannot be calculated. The only one which can be calculated is diagonal conjugate. So you have to remember, this can be a question. Which anteroposterior diameter can be calculated clinically on clinical examination? It is only diagonal conjugate. And based on diagonal conjugate's measurement, we measure true conjugate and obstetric conjugate. So obstetric conjugate cannot be measured clinically, but calculating by. And how obstetric conjugate is calculated? OC, obstetric conjugate, is equal to diagonal DC minus 1.5. Minus 1.5. So here you can see the normal is 12 centimeter. So 12 minus 1.5, it comes to around 10.5. So usually 10 centimeters is the obstetric conjugate. So that is the formula to calculate the obstetric conjugate. And this is the most important anteroposterior diameter, the obstetric conjugate. This can be a question. Which is the most important and anteroposterior diameter? It is obstetric conjugate. And which is the shortest anteroposterior diameter? It is obstetric conjugate. Now, how to calculate true conjugate? How to calculate true conjugate? Because you can get the value of diagonal conjugate on clinical examination. So you have got it, DC, diagonal conjugate, minus 1.2. Minus 1.5 is obstetric, minus 1.2 is true conjugate. So here you can see if it is 12, so minus 1.2 will come around 10.8, which is around 11 centimeter. So nearing 11 centimeters. So that is why the length is these, and only diagonal conjugate can be assessed clinically. So here is a picture where how you can assess the diagonal conjugate. So on bimanual examination, so when the two fingers are inserted, and it is seen that at one stage, the finger touches a bony structure, and that bony structure is the sacral promontory, and that gives. So after that, you have to mark it and take it out, and this wherever it touched the bony structure, and that measurement is actually the diagonal conjugate, and that is usually 12 centimeter. And from this diagonal conjugate, true conjugate and obstetric conjugate is calculated. Again, I'm telling, true conjugate is 12, or DC. I'll not tell, DC minus 1.2, and obstetric conjugate, which is very important anteroposterior diameter, that is DC minus 1.5. So you have to remember, this calculation can be a question. They can give that on clinical examination, the diagonal conjugate was seen to be so and so, maybe 12.5 or 13. Now, what is the approximate obstetric conjugate? You have to evaluate this calculation and see in which options it fits in. So that you have to remember. Next, contracted pelvis. So contracted pelvis, what is a contracted pelvis? So anatomically, a pelvis is said to be contracted if any of the major diameters, that is AP diameter or transverse diameter, are shortened by 0.5 mm or more. So this is the value anatomically if we have to describe contracted pelvis. So AP or transverse, which is less than 0.5 mm or more, then it is called as contracted pelvis. Now, obstetrically, when it comes to practical application, a contracted pelvis is that where there is alteration in size and shape of the pelvis of sufficient degree to alter the normal mechanism of labor. So normal mechanism is not able to happen, or there it is becoming difficult for normal mechanism of labor to occur, then it is called as contracted pelvis. And two criteria here, only diameters are given in anatomically, but whereas obstetrically both size can become a contracted pelvis, and shape of the pelvis also can contribute to the contracted pelvis in an average size baby, because it has nothing to do with the baby here, fetus. So if the baby is normal, the fetus is very normal in weight, and then there is a problem with pelvis, then it becomes contracted pelvis, because there are instances where the baby is very overweight baby and the pelvis is normal, then also it is a alteration in normal mechanism of labor. But here it is not contracted pelvis, whereas if there is an alteration in size and shape of pelvis, then it becomes contracted pelvis. And in contracted pelvis, the mode of delivery is always C-section. C-section, and which is the recurring cause of C-section. Although nowadays, mostly 90% of it is opted or it is elective C-section. Although, but if clinically, if we have to see which is a condition that goes to C-section recurrently, that is contracted pelvis. So this can be a question, which is the recurrent cause of C-section? It is contracted pelvis. And there is something called as Thomas dictum. This is a way how to calculate or how to know if a female has contracted pelvis or not. So if sum of bispinous diameter and posterior sagittal diameter of outlet is less than 15 centimeter, so it is usually equal to more than 15 centimeter. And if it is less, then the pelvis is said to be contracted, and it was told by Thomas, and it's called Thomas dictum. So that is the one where it is told that it is a contracted pelvis if the sum or the addition of bispinous diameter and posterior sagittal diameter of outlet, all these words are important, because easily it can become statement 1, statement 2, which of the statement 1 can be any any this one, any difference in the they can change this bispinous into biparietal or bitemporal, or they can change this outlet into inlet, and they can change this value, and they can give it as a statement 1. Statement 2 is, this is Thomas dictum to calculate or to assess the contracted pelvis. Now statement 2 or statement 1, both are wrong actually. If statement 1, the definition itself is wrong, then it is not Thomas dictum, right? So you have to understand that way. So each and every word is important. Now, what are the types of contracted pelvis? Very important. This is also again a frequently asked question in competitive exams. Rachitic pelvis. So what is a rachitic pelvis? It usually occurs in rickets. So we know rachitic word is associated with rickets, and it is also called as triradiate pelvis. When osteomyelitic pelvis, it is associated with the condition osteomalacia. Osteomalacia. So Naegele's pelvis. So what is Naegele's pelvis? One ala of the sacrum is absent. That is Naegele's pelvis. And if both the ala of the sacrum are absent, then it is called as Robert's pelvis. Robert's pelvis. So in rickets and osteomalacia, what and all changes you see in the bone of a ricketic child or osteomyelitic individual, then that is applied to the pelvis. And whereas in Naegele's and Roberts, it has to do with ala of the sacrum. And if there is one ala of the sacrum, it is Naegele's, and both the ala are absent. If the sacrum has only one ala, Naegele's, and if both are absent, it is Robert's pelvis. So very important, you have to remember these are the important points, which can be a definite question. Next, cephalopelvic disproportion. So when it comes to maternal pelvis and fetal skull, one condition that comes up is cephalopelvic disproportion. Now, what is it? What is CPD? CPD is a disparity between the fetal head and the pelvis. That means they are not proper for each other. So they either the fetal head is high or the pelvis is small. So this is the condition that occurs. So too big head or too small pelvis. And when this comes into picture, the disparity occurs and engagement is not, it doesn't occur. It is very difficult for the labor to continue. So there is something called Muller-Monroe Kerr method. Muller-Monro-Kerr method to assess CPD, and here it is the abdomino-vaginal bimanual method for diagnosis of CPD more than abdominal method. So there are two methods to assess CPD: abdomino-vaginal bimanual method and abdominal method. And which is the most what is the most used method and most convincing method is abdomino-vaginal bimanual method, and it is also called as Muller-Monro-Kerr method. Next, the best method to assess CPD. This can become a question. Which is the best method to assess the CPD? This is clinical assessment, and when it comes to investigations, it is the MRI. MRI is the best method to assess CPD, followed by CT and followed by X-ray. So this in utero. So you might be thinking these are all big topics, but only few important points have been taken, which is taken for the the high yielding or which is probable question in the exams. Now, what is fetus in utero? Let's see. So fetus in utero, there are few terms which are very important. The first starts with the lie of the fetus. And what is a lie? Lie is the long axis of the fetus to the long axis of centralized uterus. So this is lie or maternal spine. So how the fetus lies with the long axis of fetus and long axis of uterus. And usually it is longitudinal lie. Longitudinal lie. It is not transverse lie. Transverse lie is not ideal for a normal vaginal delivery. And next is presentation. What is a presentation? So the part of fetus which occupies the lower pole of the uterus is presentation, because there are two terms, presentation and presenting part. So presentation is which occupies the lower pole of the uterus, and the most common presentation is cephalic presentation. Cephalic presentation. Cephalic means head. So head lying in the lower pole of the uterus is cephalic presentation. So that is the most common. And there is something called as compound presentation. Compound presentation means prolapse of fetal extremity. Remember extremity alongside the presenting part. So presenting part can be anything. But along with that, if there is prolapse of fetal extremity, then it is called as compound presentation. And most common compound presentation is encephalic presentation, that is in head there is prolapse of hand. Prolapse of hand in cephalic presentation, that is head plus hand, that is the most common compound presentation. And most common normal presentation is cephalic presentation, and most common lie is longitudinal lie. And what is presenting part? So we saw presentation means which occupies the lower pole of the uterus. Now, which is the presenting part? Which overlies the internal os. Part of presentation. So part of presentation. Now head is the cephalic is the presentation. Now which becomes the presenting part there? So the most common is vertex. Vertex, because even bro can become a presenting part in head cephalic presentation. But the most common and ideal is vertex presenting part. And attitude. What is attitude of fetus? So the relation of different parts of fetus to one another, different parts, it is extremities, trunk, the whole body. So the different parts of the body, how it is related to each other, that is attitude. And the universal attitude of fetus is always flexion. Flexion is the universal attitude of the fetus. And this is a mechanism to occupy the uterus. To occupy the uterus. And what is the denominator? Denominator, an arbitrary fixed point on presenting part, which comes in relation to various parts of maternal pelvis. Maternal pelvis. So it is, there are various, there is not like only one thing. For example, if it is vertex is the presenting part, occiput is the denominator. So because occiput comes in relation with various parts of maternal pelvis, and mentum or chin is in the face presentation. If face is the presenting part, mentum is the denominator. And if brow is the presenting part, frontal eminence is the denominator. And if breech is the presenting part, then sacrum becomes the denominator. And if shoulder is the presenting part, then acromion process becomes the denominator. Now coming to obstetrical grips. So obstetrical grips, what are they? So they are actually Leopold's maneuver. So Leopold has given a maneuver where obstetrical grips the various obstetrical grips can be clinically assessed. So the first one is first Leopold's maneuver, which is also called as fundus grip. Fundus grip. So second Leopold's maneuver is called as lateral or umbilical grip. So these are all terms you have to remember because very easily confusing, because to recall these is difficult, and also the other names you have to remember. Easily they can give which is the second Leopold's maneuver. So the option will not have umbilical because umbilical is easy to remember, but it will be lateral, medial. So you will go for medial. That is one thing. So you have to remember the other names. Now, third grip, third Leopold's maneuver is also called as first pelvic grip. First pelvic grip, because these are related to abdomen, not pelvis, whereas third Leopold's maneuver is first pelvic grip. It is also called as Paulick's grip, Paulick's grip, and it is called as third Leopold grip. And where if there is a transverse lie, this first pelvic grip or third Leopold grip or Paulick's grip is empty. Then clinically, when the grip is cyst. So in transverse lie, it is empty, whereas in longitudinal lie, it is usually the presenting part, most commonly vertex, and that is, it can be felt, the presenting part. So this grip is usually for to know the presenting part. Next is fourth Leopold maneuver, also called as second pelvic grip. So these two are little confusing. You have to remember which is the first pelvic grip. It is not first Leopold, it is third Leopold. And which is the second pelvic grip? It is not second Leopold, it is the fourth Leopold's maneuver. And fourth Leopold, and here the second pelvic grip is done to assess the descent of the presenting part, whether the presenting part is descending or not. To assess that, the fourth Leopold's maneuver is done. So here the picture you can see, this is the fundal grip. Okay, this is the fundal grip. This is the normal longitudinal lie, the presenting part being vertex. Okay, so this is fundal grip or the first Leopold grip, and this is the lateral grip or the umbilical grip or second Leopold grip. And here you can see these have many names: Paulick's grip, first pelvic grip, and third Leopold grip. So this you have to remember. And the last one is to assess the descent. So here it is presenting part, and here it is to know the descent of the presenting part, and it is also known as fourth Leopold and second pelvic grip. So hope it is clear for you. Very important, a frequently asked question from obstetric grips, and the person who gave the maneuver is Leopold. Next is malpresentation. So different types of malpresentation, what are they? So here you can see in the picture, face presentation, brow presentation, vertex is usually normal, and breech presentation and shoulder presentation. So malpresentation, there are four. And again, this is normal, vertex is normal. So the four are: one is breech presentation, one is face presentation, breech is here and face is here, and brow presentation, this is brow presentation, and transverse lie, the presenting part will be shoulder. Now, breech presentation, it is very important, breech presentation. So you have to study in detail breech presentation, because among malpresentation, the most commonly asked question is from breech presentation. So the most common malpresentation among the four is breech presentation. And what are the types of breech presentation? And this also a very confusing part when it comes to answering competitive exams. So the types are: broadly, it is complete and incomplete breech presentation. Okay, complete and incomplete breech presentation. And complete breech is also called as flexed breech presentation. Here, the normal attitude of full flexion is maintained. Even though the presentation is a malpresentation, attitude is normal. Whereas an incomplete breech presentation, varying degrees of extension occurs. There is no complete flexion. And here it can be thighs or legs are present. So the types of incomplete breech presentation as breech with extended legs are also called as frank breech presentation. Now, because of the word complete and frank, it is very I've seen many aspirants getting confused, because frank means complete or whole. So you will relate that way. And when questions are asked, usually when frank breach is asked, directly it will be answered as a complete breach. Or what is the type of a frank breach presentation? The options will be chosen as complete breach. No, you have to remember that frank breach is a type of incomplete breach. And what is occurring there? There is breach presentation with extended legs. Legs are extended. There is no complete flexion of the legs. And which is the most common type of breech presentation? It is breech with extended legs or frank breech presentation. So in next, there is knee presentation, which is rare, and footling presentation. This is also rare. Now, these are the three types of, this is three types of incomplete breech presentation. So here you can see this is extension of legs. So when there is extension of legs, it is incomplete breech and it is called as frank breech presentation. Now this is actually this is a complete breech presentation. Okay, this is the complete breech presentation, and here this is footling. Okay, so because there is flexion here, so here the attitude of the fetus is actually complete flexion. So this is a complete breech presentation. This is incomplete breech with extended legs, and that is called as frank. And this is incomplete breech with footling presentation. So it is called as footling presentation. Now, when it comes to breech presentation, which is the most common malpresentation? It is breech presentation. And which is the most common breech presentation? It is frank breech, also called as breech with extended legs. So this much you have to remember. And how it is diagnosed? Usually by USG. Breech presentation usually by USG. And there is something called a stargazer or flying fetus. Stargazer or flying fetus. So it occurs in 5% of breech presentation where fetal head may be in extreme hyperextension. So when there is extreme hyperextension, the fetus will not be engaged, first of all. So that is why it is called as flying fetus or stargazer fetus. Now, the lie in breech presentation is usually longitudinal, and presentation is podalic. Podalic means usually feet or the lower part is the presentation, and or breech, that is the lower part, not the head presentation. So that is called as podalic, and denominator usually sacrum in breech presentation. And position of the fetus, most common position is left sacro-anterior. The risk of cord prolapse is maximum with footling or knee presentation and least with frank breech presentation. And this footling and knee are actually rare presentations. The most common is frank, whereas in frank, cord prolapse doesn't occur that highly. It is maximum with footling or knee presentation. Now, etiology of breech presentation, and this is also asked in question papers. So, which is the most common risk factor or etiology for breech presentation? It is prematurity, or there is not sufficient growth of the fetus, and that is why it is easily the malposition is occurring and the presenting part is becoming malpresentation. The factors preventing spontaneous version of the uterus, whereas it occurs in twins. Oligohydramnios, when there is less amniotic fluid, septate uterus or bicornuate uterus, when there is a short umbilical cord, and when intrauterine death has occurred, then usually the fetus will take up the position of breech presentation. Now, which is the favorable adaptation? Where so see, breech presentation, one cause is prematurity. So preventing spontaneous version, the factors which prevent spontaneous version are these, and the factors where the favorable adaptation occurs. So the breech presentation is the favorable adaptation, so that the pathological condition is making the fetus to go into that presentation. So that is hydrocephalus. Placenta previa, as we discussed earlier. So the placenta is a low-lying placenta. So what happens? The placenta, the weight of the placenta is pulling the fetus and then getting the fetus into the breech presentation and contracted pelvis. So these are the etiological factors. And multipara who has given birth to many and with a lax abdominal wall. So this usually occurs, what happens when there is no spacing between the two pregnancies. So that and there is multiple pregnancy. So their breech presentation is common. And what are the fetal abnormalities where breech presentation is seen? It is trisomy 13, 18, 21, anencephaly, and myotonic dystrophy. So these are the conditions where breech presentation is seen. Now, what are the maneuvers in breech delivery? Very important. Love set maneuver for the delivery of arm. So this is asked, which is the maneuver used for the delivery of arm in breech presentation? It is love set maneuver. And Pinard's maneuver, it is used in frank breech, converts frank into footling. So what happens, this maneuver, when it is used, when it is done in frank breech, the frank is converted into footling, and that will help in which is not complicated usually. And maneuvers for after coming head. After coming head, what are the maneuvers? Because in breech presentation, first the expulsion is not of the head. It is of the lower part, and after that head comes. So what are the maneuvers for that is, it is Burns-Marshall technique, Bracht maneuver, and Mauricio Smalley-Witt technique. This is malar flexion and shoulder traction is done, and Wigand-Martin technique. So these are the 4 maneuvers for after coming head. So you have to remember the names. You have no choice but to remember the names because it is asked. All the 6 maneuvers are asked in the questions. And Piper's forceps, there's something called as an instrument called as forceps, type of forceps, Piper's forceps. It is specially designed forceps for after coming head in assisted breech delivery. So when the question is about breech delivery, you will always think the delivery of the podalic part. So don't get confused. The forceps is to deliver or to assist the breech delivery for the after coming head. Now, face presentation. Presenting part is face here, and denominator is mentum or chin. And the most common position in face presentation is left mento anterior. And most common pelvis where face presentation occurs is platypeloid pelvis, and which is the least common type of pelvis and also called as flat bowl-like pelvis. And here, what is the specialty? Transverse diameter is more than anteroposterior diameter. And most common cause of face presentation is anencephaly. Anencephaly. Next, brow presentation. And brow presentation is the rarest presentation. So which is the rarest presentation? It is brow. So you can remember RR. So rarest presentation is brow presentation, seen in partial extension of head, seen with where and all it can be seen: anencephaly, platypeloid pelvis, multiparity, and fetal macrosomia. Macrosomia, big head. And there is no mechanism of labor. When it comes to brow presentation, it is not, there is no assisted delivery, there is no assisted vaginal delivery. Directly it is taken for C-section. So it is not a point of question to see whether normal vaginal delivery can happen or not. So 2 conditions, it is one is brow and one is transverse. Transverse also no chance of normal vaginal delivery. It is always taken for directly for C-section. Now presentation in a transverse lie is shoulder presentation, and most common position of the fetus is dorso-anterior, and there is no mechanism of labor. Delivery is by C-section. Cord prolapse is maximum with transverse lie, And whereas when we read about breech presentation, in the type of breech presentation in which cord prolapse occurs, in type of breech presentation, it is knee or footling. It is not common in the frank breech. So which is the common where cord prolapse occurs in breech presentation? It is knee or footling. And overall in malpresentation, which presentation has most maximum cord prolapse? It is transverse lie. Next, obstructed labor. So obstructed labor is one where in spite of good uterine contraction, so there is good uterine contraction, there is nothing to do with uterine contraction, progressive descent of the presenting part is arrested due to mechanical obstruction. So here what is happening? There is mechanical obstruction. So patient is in agony and exhaustion and ketoacidosis. So here obstructed labor is a very painful condition or a very difficult condition for the women in labor. And per abdomen, what are the findings in obstructed labor? Since the uterus cannot empty, Descent is not happening. The thinned lower uterine segment keeps on elongating because contraction is happening. Contraction is normally happening, but the descent is not happening. So sometimes a palpable ring, pathological retraction ring or Bandel's ring is seen. So we saw when we had seen the uterine contractions, there is something called as retraction ring in the lower uterine segment, which is responsible for the retraction, and which is followed after contraction. So what happens in obstructed labor, this retraction ring, which is physiological, becomes pathological, and that ring is called as Bandel's ring. And why this is occurring? This is because of the thinning of the lower uterine segment and elongation of lower uterine segment with continuous uterine contraction, and there is no descent of the fetus. Forms in between upper and lower uterine segment. And upper part is hard and tender, and fetal parts are not well defined in per abdomen examination, and FHS, the fetal heart sound, is absent in obstructed labor. Obstructed labor is a very difficult condition. So immediately the lady or the women in labor is taken for C-section. Vagina, per vagina, dry, hot, and the discharge is very offensive. Cervix is fully dilated, and membranes are absent. Bandel's ring cannot be felt vaginally, and if obstructed labor is occurring and waiting is this wait and watch thing is done, there will be immediate uterine rupture, and that is why it is a critical condition. Immediately the woman is taken for C-section. So the most common cause of vesico-vaginal fistula in a lady who has given birth and there is a condition obstructed labor, she has gone through obstructed labor, then the most common cause of vesico-vaginal fistula is obstructed labor. Next is hyperemesis gravidarum. So hyperemesis gravidarum, it is a refractory vomiting. So we know this is nausea and vomiting is one sign which occurs as a presumptive sign in when we saw about diagnosis of pregnancy. So there, one of the presumptive sign in the first trimester is nausea and vomiting. And this nausea and vomiting, if it becomes very severe, then it is called as hyperemesis gravidarum. So refractory vomiting leading to weight loss, typically persisting beyond 14 to 16 weeks of gestation, because by 14 weeks, this nausea and vomiting should stop, because the mechanism there is because of the presence of beta-HCG. So when after 14 weeks, the normal physiological change is that beta-HCG comes down because of the regression of corpus luteum. But whereas in hyperemesis gravidarum, the beta-HCG, for some reason, this nausea vomiting will not come down by 14 to 16 weeks. It just persists beyond 14 to 16 weeks. And that condition, and where the vomiting is very severe with weight loss, it is hyperemesis gravidarum. So emesis means vomiting, and hyper means excess. So excess vomiting. Gravidarum means who is pregnant, so a pregnant uterus. So a pregnant woman who has excess vomiting is called as hyperemesis gravidarum. So hyponatremia, what an all condition comes up with this hyperemesis gravidarum pregnant lady? She will suffer from hyponatremia, hypochloremia, hypokalemia, and metabolic acidosis. So these are all consequences of loss of vital fluids. And transient hyperthyroidism may occur. Common risk factor for hyperemesis gravidarum, though why it is occurring, the exact mechanism is not known, or is the exact etiological factor is not known. The risk factor is multiparity, a woman who has given more births, and multiple pregnancies. That means there is no spacing between the pregnancies, and trophoblastic disease. These are three common risk factors. Other risk factors being family history of hyperemesis gravidarum. That means the mother of the girl who is pregnant had a history of hyperemesis gravidarum, then the daughter will also have the tendency to suffer from hyperemesis gravidarum. Young age pregnant, that means very early age she's got pregnant, then it is another risk factor. And low body mass, that means underweight girl or underweight women who is giving birth or who has become pregnant, then it is common. And there is history of motion sickness. So car sickness, all this motion sickness, there is history, and since childhood, and then that women who's got pregnant will have the risk of getting hyperemesis gravidarum. And migraine, and more common risk factor is unplanned pregnancy. unplanned pregnancy. And here there is a lot of anxiety issues which is coming up, and nausea and vomiting is associated somehow psychologically. So that is why it is seen that when there is unplanned pregnancy, hyperemesis gravidarum is more common. Next topic is pre-eclampsia. So these are all small topics which is important from the exam point of view. I've covered only the main important points. Pre-eclampsia is, we all know there is a hypertension or the increased BP which is coming into picture when the word pre-eclampsia or eclampsia comes up. One word that should come up, or one condition, is hypertension. Hypertension should come to your mind. And along with hypertension, what occurs? Proteinuria and edema. So these three constitutes pre-eclampsia. So there is proteinuria, there is edema, and there is hypertension. So there are two categories, mild and severe preeclampsia. So in mild preeclampsia, the BP is more than 140/90. So if the BP is more than 140/90, we know it is ideally hypertension. So that is that happens in mild preeclampsia, and more than two occasions. So this 140/90 not only once, more than or equal to 2 occasions, and proteinuria more than 300 milligram per 24 hours after 20 weeks of gestation. If this is seen, then it is mild. Whereas in severe preeclampsia, what happens? The BP shoots up to 160/110 mm of Hg. So 160 by 110 by mm of Hg. And again, here it is two or more occasions, and proteinuria is more than 5 grams. 5 grams. That means 5,000 milligrams. It is not 300. If it is 300, it is you should really value combinations of eclampsia. So this is important. It is usually frequently helps hemolysis, elevated liver enzymes, elevated liver enzymes, and low platelets. So when it is seen, easily they can confuse you with 5 terms. When it you can see HELLP, so they can give HELLP one term. Okay, there will be one option where there are only 3 terms. Okay, 3 terms. So you have to understand. So HELP syndrome means hemolysis, H for hemolysis. EL means elevated liver enzymes, and low platelets. LP means low platelets, and this is one of the complication of preeclampsia. Preeclampsia going into the hemolysis liver with elevated liver enzymes and thrombocytopenia is HELP syndrome. Now, what are the CNS complications or associated CNS complaints? One is headache, blurred vision, and following by seizures and coma. So these are the complicated picture of a preeclampsia. Renal dysfunction, usually it is oliguria and creatinine more than 1.5 milligram per dl. Pulmonary edema is a complication. Hepatocellular injury is a complication. Placental dysfunction is a complication. Now coming to eclampsia. So pre-eclampsia, we saw proteinuria, edema, and hypertension. Now what is eclampsia? Eclampsia is pre-eclampsia with seizures. If seizures or fits or epileptic seizures occurs, then it is the condition is called as eclampsia. Eclampsia. So remember E for epilepsy or seizures, and pre-eclampsia means again what is happening? Proteinuria, edema, and hypertension. So proteinuria, edema, hypertension with seizures is eclampsia. So the most common is antepartum eclampsia, which is fits before the onset of labor. So usually eclampsia case, what happens? When does the seizure occurs? It occurs before the onset of labor. The risk factors for eclampsia are nulliparity, not given birth once also, and DM, that is diabetes mellitus, history of renal disease or chronic hypertension in a woman who has become pregnant now, a prior history of preeclampsia. Already the woman is diagnosed with preeclampsia, the risk is an eclampsia, and extremes of maternal age. This is not age. Okay, extremes of maternal age, especially more than 35 years and less than 20 to 21 years. Okay, so this is the extremes. That means high age and low age, both are a risk factor, and obesity is one of the risk factor. Antiphospholipid antibody syndrome. So these are the risk factors for eclampsia. So these are the important points when it comes to eclampsia. Next is gestational diabetes mellitus. So we know diabetes mellitus, we know DM, and gestational means pregnancy. So diabetes mellitus, which occurs in pregnancy. So DM diagnosed. It should be properly diagnosed during pregnancy. That is gestational diabetes mellitus. The risk factor for gestational diabetes mellitus is obesity, family history of diabetes mellitus, and previous history of diabetes mellitus. Now, what are the complications of gestational diabetes mellitus? Fetal complications are congenital malformation, stillbirth of the fetus, and intrauterine growth retardation, hypoglycemia, birth trauma, shoulder dystocia, this will be discussed, polycythemia, hyperbilirubinemia. Children are at high risk of being obese in childhood or adulthood. That means a woman who has given birth to a child who was diagnosed with gestational diabetes, that child has a high risk of becoming obese in childhood or adulthood, and that child also has a high risk of suffering from diabetes in the future. Maternal complications are perineal trauma from macrosomic infant because the increased weight of the fetus. Two complications or two: obesity and diabetes mellitus. Obesity in pregnant women and gestational diabetes mellitus are the two conditions which are associated with macrosomia and increased lifetime risk of developing. So this mother who has been diagnosed with gestational diabetes, few mothers will, after the pregnancy or after the delivery, they become normal. Their sugar levels all become normal, but that mother is prone to get diabetes again in her future life. Now, how is the diagnosis done for gestational diabetes? One-step method is there and two-step method is there. So one-step method, what happens? Women is given 75 gram oral GTT. GTT means glucose tolerance test between 24 to 28 weeks gestation. So it is done after an overnight fast of at least 8 hours. The diagnosis of any high values, any one of it becomes, any one high value, then it is diagnosed as gestational DM. So if fasting is more than 92, if 1 hour there is postprandial is 180 milligram per DL, and 2 hours it is 153 milligram per DL after giving 75 gram oral GTT, then any of the one of the becomes high, then it is diagnosed as gestational diabetes method. Now, when it comes to two-step method, it is a two-step. That means first step is 50 gram is given. 50 gram is given between 24 to 28 weeks gestation. And again, here, if the plasma glucose after 1 hour is assessed. So this is the second step. So this is the first step. And second step is assessing the plasma glucose after 1 hour. And if it is higher than 140, only then 100 gram of oral GTT is given. So if it is not high, then the second step is not done. That means the 100 gram oral GTT is not given. So after 100 gram oral GTT, any two of it becomes high. So here it is not one, it is two. So if fasting is more than 95, 1 hour more than 180, 2 hours more than 155, and 3 hours more than 140, any two of it becomes high, it is diagnosed as gestational diabetes mellitus. So this table you have to remember, and easily this is a question which can be framed. Ectopic pregnancy. So ectopic pregnancy is implantation of fertilized ovum outside the uterus, So most common is ampulla of the fallopian tube. When this is seen, a few aspirants get confused why this is a pathology. So you have to understand fertilization occurs in fallopian tube, but implantation doesn't occur in fallopian tube. So implantation always occurs in the uterine cavity. So the most common site of ectopic pregnancy, which is outside the uterus, is ampulla of the fallopian tube. Other than that, it is ovary, cervix, and abdominal cavity. The risk factors of ectopic pregnancy is PID. One of the common condition associated with ectopic pregnancy is pelvic inflammatory disease and history of any sexually transmitted diseases. Prior ectopic pregnancy, there was history of ectopic pregnancy. Again, the woman has got pregnant. Then again, the woman is prone to get ectopic pregnancy. Prior any gynecological surgery has been done, and multiple sex partners, it is seen that it is one of the risk factor. And POP, progesterone only pills. Okay, don't think it is something related to orthopedics. It is progesterone only pills. Okay. So it is one of the risk factors for ectopic pregnancy. Clinical features, usually there is abdominal pain, and there is severe abdominal pain if the ectopic pregnancy gets ruptured. When there is rupture and vaginal bleeding is seen, pelvic mass is felt, and diagnosis is done by increased beta HCG. Increased beta HCG test with USG, unable to locate intrauterine pregnancy. So what happens in normal intrauterine pregnancy is beta HCG for intrauterine pregnancy doubles every 48 hours. So this is the usual scenario when beta HCG is calculated. Every 48 hours it doubles. So that means it is actually producing more HCG every 48 hours. Whereas in ectopic pregnancy, and this happens only in intrauterine normal implantation. In ectopic pregnancy, this beta HCG doesn't double after 48 hours. And that is one sign that the pregnancy is ectopic. And one more condition where this doesn't double is pseudocyesis. Pseudocyesis. This was earlier discussed in other session. So pseudocyesis means false pregnancy. So here also beta HCG is calculated and it doesn't double after 48 hours. Most common site of ectopic pregnancy is fallopian tube. So these are few points which are very important when it comes to questions. So, and most common site in fallopian tube, which is the most common site for ectopic, it is ampulla. And most common site of rupture of ectopic pregnancy is isthmus. So rupture will happen usually in isthmus of fallopian tube. Most common risk factor associated with ectopic pregnancy is progesterone only pills or progestin only pills. Most common mode of termination of ectopic pregnancy is tubal abortion. Next, intrauterine growth retardation. So here the estimated fetal weight at or below the 10th percentile of gestational age. And fundal height and gestational age difference is more than or equal to 2 centimeter, which is not usual. So there are two types of IUGR. IUGR is basically the fetus is not growing approximately for the gestational age. So symmetric IUGR and asymmetric IUGR. So symmetric IUGR, what happens? The fetal and body and fetal head growth is similarly affected. That means symmetrically the baby or the fetus is not growing. It indicates that the cause of IUGR occurred in early pregnancy. That means first trimester itself. And here the most common cause is genetic or viral infections. Asymmetric is somatic growth, that is abdomen circumference and the lower body shows significant delay. It is smaller, whereas the head growth is where that means head growth is normal, whereas the body, abdomen circumference and lower body is not growing for the gestational age. And here the common condition associated is uteroplacental insufficiency. And causes of IUGR, the fetal causes are chromosomal abnormalities, and the most common chromosomal abnormality for IUGR is trisomy 21, followed by 18 and 13. And infection is one of the fetal cause. And here the most common infection which leads to IUGR is CMV, cytomegalovirus infection, and toxoplasmosis also, and placental abnormalities. Maternal causes are hypertension, drugs, systemic lupus erythematosus, malnutrition, and thrombophilia. And here in drugs, the most common maternal cause for IUGR is, this is asked actually, very important. So most common cause for IUGR is smoking. In maternal cause is smoking. Next, hydatidate form mole. So here I just want to see the picture. Here you can see grape-like vesicles. Okay, so this is called as grape-like vesicles. So hydatidate form mole means it is a benign neoplasm. Benign, it's not malignant, but it is capable of transforming into a malignant condition. So it is a neoplasm of trophoblastic cells or placental cells. So carries the risk of malignant transformation. And there are two types, complete mole and incomplete mole. Complete mole, the chromosomal pattern is 46XX and it is completely paternal in origin. And partial mole or incomplete partial mole, it is triploid or tetraploid. So here the chromosomal pattern is 69XXY. So here it is, it contains fetal part also. The risk factor for hydatidate form mole is low socioeconomic status, age more than 40 years, the women, and Asian heritage, tobacco use, pre-eclampsia in first half of pregnancy. The signs of on examination, the signs are uterine size is more than gestational age because of the neoplasm or a benign this one growth, and hyperthyroidism is seen. Expulsion of grape-like vesicles in the vagina. So you have to remember there are two terms which come up in hereditary form mole. So it is grape-like vesicles from a vagina. That is on clinical examination. This is on clinical examination, and no fetal heart sound. Fetal heart sound is not heard, and beta HCG is high, increased for gestational age. And when it is USG is done, radiological feature. So don't get confused with clinical examination feature and radiological feature. Clinical examination feature is grape-like vesicles, which is seen from the vagina, and USG or radiological feature is snowstorm appearance. Snowstorm appearance. Usually when USG is done, we have to see a gestational sac. But here there is no gestational sac. So here it is snowstorm appearance in the USG. Complication or the transformation which usually occurs is choriocarcinoma. So difference between complete and partial mole. So the karyotype in complete is 46X X on XY. Here it is triploid. So 69XXY or 69XYY. So villus edema, all villi is involved, and here some villi is involved. Trophoblastic proliferation is diffuse and circumferential and complete. Focal, it is focal, and slight in partial. Fetal parts is rarely seen in complete, more common in partial, and atypia is often present in complete mole and absent in partial mole. Serum HCG is very much elevated in complete mole, and partial mole least elevated. But overall, in any type of hereditary form, mole HCG is raised. And HCG in tissue is very much high in complete, and it is high in partial. And transformation or malignant transformation, 2% choriocarcinoma. Rarely in partial mole, it is choriocarcinoma. Next, there is a condition called shoulder dystocia. So in brief, I will just tell. So what happens in shoulder dystocia? Here it is anterior or posterior. Anterior or posterior fetal shoulder impacts on the maternal symphysis or sacral promontory. And this what happens, the shoulder delivery becomes difficult. When it is impacted, the shoulder delivery becomes difficult. So if it is anterior shoulder, then it impacts in the maternal symphysis. If it is posterior shoulder, it impacts in the sacral promontory, but posterior is rare actually. Posterior is rare, and incidence is about 0.2 to 1%. That is the incidence. And most common risk factor is maternal DM. So maternal diabetes mellitus, obesity. These are the risk factors, obesity. And here the obesity can be maternal obesity also and fetal obesity also, macrosomia also. So both the conditions will contribute for shoulder dystocia. And preterm fetus and anencephaly. These are the four anencephaly. These are the four most important risk factors for shoulder dystocia. And then what are the complications? The complications of shoulder dystocia is divided into fetal and maternal. So what are the fetal complications? It is asphyxia, because the delivery is not happening. Shoulder delivery is not happening. So the fetus will go into distress. So asphyxia will occur. And then there is brachial plexus injury, and it will go into Erb's palsy. So which is the most common cause for Erb's palsy or Klumpke's palsy in a fetus? It is actually because of shoulder dystocia. This you should remember. Klumpke's palsy and Erb's palsy. And there is humerus fracture. There are few conditions where humerus fracture can occur. This is one of the complications. And maternal complications are PPH, postpartum hemorrhage, PPH, cervical laceration, and vaginal tear, so laceration, and perineal tear, and uterine rupture can occur. And bladder rupture also can occur, because there is continuous pressure of the shoulder and the fetus, because it is not being able to deliver after the head has come out. So this is shoulder dystocia, and there are few maneuvers which are used for to deliver the shoulder. First one is Mr. Roberts maneuver. So just remember the names. And Wood's screw maneuver, and Robbins maneuver, Jacquemier's. So you will remember in the diagnosis of pregnancy, Jacquemier's sign. So Jacquemier's maneuver is used in shoulder dystocia, and Gaskin's maneuver, and Zavanelli maneuver. Zavanelli is actually rare; it is not used. So these are the maneuvers. So most common is Mr. Roberts maneuver, Mac Roberts maneuver. And here what happens is the maneuver is done with hyperflexion of mother's legs. This is important. Which is the maneuver where hyperflexion of mother's legs is done in shoulder dystocia? It is Mac Roberts maneuver. So this completes all the small topics. So I would tell the aspirants to go through the topics again and again, and go through the question papers also again and again, and see what is the important topics. Thank you, Focus, for giving me this opportunity. Thank you.